everyone. Thank you so much for listening to this presentation, Fact versus Fiction, Tackling Common Contact Lens Myths. So we're going to have a bit of fun in this lecture. I hope you take a pearl or two away and you can bring it back to clinic when you're there next. But let's talk about contact lens myths today. So I'm very fortunate to help grow our wonderful industry of eye care, which I love. Please connect with me so we can continue that discussion on Insta or LinkedIn. I have a podcast too, Globalize, which we're not going to be talking about in this lecture. Okay, let's start with the first fact or fiction. Contact lens wearers must wear contact lenses full time. Now, think about that. So think about maybe back when you were in school a year ago or 20 years ago or whenever it was. What did you learn about contact lenses? Did you learn that patients had to wear contact lenses all day, every day, like they were a contact lens wearer? Or did you learn maybe that they could have contacts and glasses and some other things too? So let's chat about that. The global contact lens market is huge. So it's actually valued in US dollars at 7.84 billion in 2020, and the contact lens market is expected to grow from 8.58 billion in 2021 to 12.56 billion in 2028. That compound annual growth rate of 5.6% in that forecast period up to 2028. So think of this as opportunity. We have all these people that are interested in contact lenses, and we'll talk about different lens types for everyone as well. Just looking at North America here, the US is 4.45 billion in 2021. That's the contact lens market. 6.37 billion by 2026, CAGR of 7.45 up until 2026. So again, huge opportunity. But we know that as with age and with time, and I never ever say age to my patients, but with time, over the years, whatever you want to say, there's a huge opportunity for contact lens wear as ametropia increases. So any sort of refractive error, whether that's myopia or hyperopia, presbyopia, we're going to talk about that in just a moment. But past the age of 45, ametropia doubles, and half of contact lens wearers actually drop out past the age of 45 years. So we have ways that we're going to talk about tonight or today or tomorrow or whenever we are to talk about contact lens wear. So contact lens usage really dramatically drops off with age. This is looking at presbyopes. 93% of presbyopes were not wearing multifocal contact lenses at the time of dropout. So we have this huge potential opportunity. But let's just bring it back to contact lens wear in general. So the question is, does everyone have to be a full-time contact lens wearer? And I will argue not at all. Contact lenses offer so many different benefits. And I would encourage you to bring up contact lenses with all of your patients. We have all sorts of options now for different types of patients, right? We have glasses, we have contact lenses, we have surgical options. And now for presbyopia, we even have pharmaceutical option, more options to come shortly. So let's talk about the benefits of contact lenses. And I'll just share a quick story from this week. Is a mother came in and I've seen her for years, and she was talking about her 13-year-old daughter who has astigmatism and myopia. And she's a little resistant. She's not interested in wearing contact lenses, but the mother really, really wants her to wear contact lenses. So I said, well, your daughter needs to want to wear contact lenses, but let's talk about the benefits of contact lenses. So contact lenses really offer great peripheral vision. They offer the freedom from glasses, a youthful appearance, glasses free, so getting rid of glasses, and people can wear contact lenses for part-time wear, for sports or social occasions. And I like to ask my patients specifically when they would like to wear contacts. Are they interested in contact lenses to wear all day, every day, which is great? Are they interested in contact lenses for specific activities, for sports? And if so, what type of sports? because that depends on what type of contact lens I'm going to fit, or going out, social. Do they want to wear them at a certain time of day? And what do they do? Of course, during the day, what do they do for work? What do they do for fun? Are they a student? But we have lots and lots of different benefits for contact lenses. So going back to that story of the 13-year-old girl, her mom is going to just bring her in for an exam, take all the measurements. And I said, I'll talk to her about different contact lens options. And there are definitely contact lenses for everyone because contact lenses do offer so many benefits. But they also offer benefits for your practice. So say a patient has presbyopia, they reduce the need of self-prescribing over-the-counter reading glasses. Contact lenses set you apart in your practice. So they fill a need and a want, and they really differentiate your practice, making your patients very happy, improving retention and loyalty. And your patients are going to refer their friends and family to you to fit them with contact lenses, which increases the revenue in your practice. Now, just think of a contact lens wearer in general who needs glasses. All contact lens wearers need glasses. And say if the person wears contact lenses, they also need sunglasses to wear over their contact lenses when they're outdoors, even if their contact lenses have the benefits of UVA and UVB protection. And what about mask-associated dry eye? In our clinic here in California, patients are still wearing masks. We're still wearing masks. And we know we're very familiar with mask-associated dry eye, the drying effect on the ocular surface when hot air blows upwards in the eyes and causes lots and lots of fogging, not only for the patient who wears glasses, but for us doing our exams every day, right? We have fogging behind the phoropter. There's fogging with our lenses. We tend to tape the top of masks most of the time to prevent this fogging. And mask-associated dry eye leads to tear film evaporation, causing more ocular discomfort and irritation. So poorly fit face masks can really be the cause and contribute, but contact lenses are such a great option to just get rid of mask-associated dry eye. They can really solve our problem. So these are some nice graphics from CORE, and you can see, but still, there are lots of patients who are still wearing masks in my clinic. And I ask my patients if they're wearing a mask, and if so, how many hours are they needing to wear a mask? Is it an hour or 30 minutes a day, or is it an 8 or 12-hour day? Because it really makes a difference for the ocular surface. So we can tape the mask. We want to make sure we don't tape the eyelid, and we want a mask with the pliable nose wires to really tuck it in there. We can use topical lubrication even over contact lenses. There are many great eye drops, even over-the-counter drops to use over contact lenses. We want to limit the time in air conditioning. We don't want hot air or cool air directly blowing on the eyes, avoiding fans, breaks on digital devices, the 20-20-20 rule, and hydrating, reducing caffeine, although a little bit of caffeine is okay, but drinking lots of water is very important as well. Okay, so we're on to the next one. Fact or fiction? Daily replacement contact lenses are wasteful. And I've had this discussion with many people in different parts, and it seems like it depends on where you practice to how big of a deal this is. Now, I'm in California, and this is huge. I have patients who come in and they say, well, I don't want to wear daily replacement lenses because it's such a waste. Why would I open a new package every single day when I could have a lens that I clean and reuse and rewear, and I don't want to do it at all? So I hope that you share the following slides and information with your patients if you're in the same sort of practice situation that I am. So it's really it's a good conversation starter, but it's also helpful to explain the benefits of a daily replacement lens, which we know. It's the cleanest, healthiest lens that someone can wear. And also, it's just so convenient. So when you're fitting a contact lens, if you change to a daily replacement lens, it's so easy for the patient at the end of the day. I have patients who are in bed, they take their lens off and throw it away or whatever. But there are lots of options. So let's talk about this. Are contact lenses, daily replacement contact lenses, wasteful? So we know that plastic is everywhere. And in doing some research on this topic, 32% of plastic packaging ends up in the ocean every single year. And more than 90% of plastic has never been recycled. And we've heard about this more in the media. We've heard about plastic straws. And here in California, depending on where you are, we don't have plastic straws. It depends on where you live. And let's just look at the daily replacement contact lens market penetration. So looking at daily lenses, this came from Contact Lens Spectrum in January 2022. Looking at daily lenses, 43% in daily, which is so much better than it was 10 or 20 years ago. Weekly or 2-week, 19%, monthly replacement, 34%, and quarterly down to 3%. Just for fun, I always think, well, that's great. And now what percentage is SiHy and what percentage is hydrogel? So I included that in there too. So the SiHy is almost 70, the hydrogel 20, and then we have our PMMA just at 1%, but there are still a few patients out there in PMMA lenses, hybrid lenses at 2%, and GP at 7%. And so back to the question, are daily replacement contact lenses wasteful? Well, this was a study. This was an actual study done that demonstrated that 15 to 20% of contact lens wearers flush their contact lenses down the sink or toilet. And I read the study, it's from ASU, and I was shocked. Like, what? Really? I guess this happens. I guess people do this. I was blown away by this. An annual supply, this is information you can share with your patients. An annual supply of daily disposable contact lenses, 365 pairs, produced 11.36 grams of dehydrated plastic waste. Now, if we have a regular plastic water bottle, that's equivalent to the weight of 1,586 dehydrated contact lenses, a 2.17-year supply. And that is amazing. So you can use this information if patients are concerned about daily replacement contact lenses to compare it to just a water bottle. Now, we know that reusable lenses, anything that's biweekly or monthly or quarterly, need solutions and bottles and cases. And we need to, of course, replace the solutions and bottles and cases for our patients. And this is one of my favorites, I think. A single bottle of multi-purpose solution, the average weight is equivalent to 2.5 years of daily replacement contact lenses. So when I talk about that, patients say, oh, wow, oh, yeah. And I also bring in here the cost of solutions, because some of my patients think, oh, no, daily replacement lenses are just way too expensive. And then I talk about, well, we do need to consider the cost of the contact lens solution as well as the contact lenses, because that matters a lot. And a peroxide case alone is equal to more than 8 years of contact lenses. So hopefully this has convinced you that daily replacement contact lenses are not wasteful at all. Now, this is important. We can recycle, and we can recycle in the number 5, recycling. It has a high melting point, and there are many companies now that have jumped on this bandwagon, which I think is fantastic. And I'm just going to go through some of the companies and what they're doing for recycling. So Bausch & Lomb has the 1x1 and BioTrue eye care recycling program. And look at all of the millions of units and pounds of used contact lenses, eye care, and materials that have been recycled. So it's equivalent of the weight of approximately 31 elephants. Now, I will ask you, do you weigh elephants? I know I don't, but I thought that's a kind of a fun statistic there. CooperVision has a campaign going on of the first of its kind plastic neutrality initiative. This is expanded to countries in Europe and Latin America and will soon launch in Asia as well. Alcon has earned the Green Circle Zero Waste to Landfill certification for 3 ophthalmic drop-in solution manufacturing facilities, 2 in Fort Worth, Texas, 1 in Singapore. And then Johnson & Johnson is committed to achieving carbon neutrality in all of its operations by 2030. And there are changes in how products are made and manufactured and distributed. And all AccuView brand contact lenses are made with 100% renewable electricity. So their goal is to source 100% of the company's electricity needs from renewable energy 2 years early. Now, there's a video here to show what they're working on. Isn't that a peppy, fun video there? And you can give your patients little boxes to recycle their contact lenses from multiple companies. In our practices, we actually have larger boxes to recycle contact lenses as well. Okay, moving on to the next topic, fact or fiction. Multifocal contact lenses don't work. And I included this because this was a year or two ago. I had a conversation with a doctor, and she said to me, multifocal contact lenses don't work. And I looked at her like, what? What? And so I'm going to try and convince you that multifocal contact lenses work very, very well. And we have lots of different options for multifocal lenses. This week, also, a question came up, well, are fitting multifocal contact lenses, is it always a compromise compared to glasses? And I said, absolutely not, because we have many different tools in our toolbox. We have, and just in multifocals, and we're going to talk about that in the next few slides here. So we know about presbyopia. It's inevitable. Everyone who lives long enough is going to be presbyopic. Presbyopia does affect 128 million Americans, and about 1.8 billion are affected globally. And many people buy over-the-counter reading glasses. But patients are frustrated. They don't want to wear reading glasses, and I don't want my patients to be wearing reading glasses over their contact lenses either. So this is interesting going from a patient perspective. Patients feel frustrated when they forget their reading glasses. They make them feel old. Not having to wear glasses helps with confidence. Oh, and I forgot to say that earlier, is that I love the study looking at contact lenses for kids and showing their increase in confidence. That's another great point there too. Now, who's presbyopic? Millennials. Millennials are presbyopic at this point, and it's the largest generation. They don't want to be wearing glasses at all. This is really impactful. This study looked at many different presbyopes, about 1,000, and reported that the loss of near vision was the #1 impact on quality of life compared to other age-related ailments. So including dry eyes was only at 14%, which is so interesting to me because I feel like dry eye really affects people, but near vision is a big deal. So there's a new presbyopia classification that hopefully you've seen. I would encourage you to download it. It's a publication that goes over different levels of presbyopia. So mild, moderate, and advanced. And it's really not based on age at all. It's based on an individual person. So if you want to assign an ad to it, we have 3 different ad powers here. The take-home point of this are 2 points. 1, please measure near vision, however you might want to do that, whether it's a card, whether it's a picture, whether it's having your patient pull out their phone and documenting information on what they're seeing there. But what I learned from the classification here is that it's really not based on age. So a person could be 40 years old and be a moderate or advanced presbyope, or a person could be 75 years old and have mild presbyopia. So really important, we need to ask our patients what they're doing and have them bring in even what they're working on, say a laptop computer, or if they do beadwork or something like that. It's really helpful to measure their presbyopia and to correct for it, and based on what they're doing. Okay, and in the classification guidelines, there are different examples there as well. So we have lots of different options for presbyopia. We have multifocal contact lenses, we have modified monovision, we have distance contacts with reading glasses, and monovision contact lenses. So if we go back to the studies, and I always love going back to the studies, what do the studies say? Well, the studies really do demonstrate the benefits of multifocal lenses. So here you can see on the left, this is a monovision versus an essential GP. There were 75% preference for multifocal. If we look at the next study, the monovision versus a soft lens multifocal, 76% preference for multifocal. However, there were issues with near vision and low light. Monovision compared to a different bifocal, almost 70% preference for multifocal, same issues of near vision and low light, and it goes on and on. Now, I want to draw your attention to the bottom right study here, Woods in 2009. And this is looking at objective or exam room testing versus subjective or real world. And what's the most important for your patient? I would argue it's their real world lives. It doesn't matter if they can see 20/20 in my exam room. I want to make sure that they're seeing well when they're reading and driving and on the computer and playing tennis or whatever they might be doing. So in this study, monovision was the best performer for high and low contrast near vision tests. But monovision was the lowest performer, and multifocal contact lenses were the highest performer for doing all of their activities. So really great point there to consider multifocal contact lenses. So the numbers don't lie. Okay, only 8% of presbyopes have been told about multifocals. I really hope this is not true. 1 in 3 presbyopes want to try multifocal lenses. 1 in 3 patients would switch doctors if they're not told about multifocals. I hope that's not true also. But we do know that most patients do want to stay in contact lenses with time. So 91% of contact lens wearers age 35 to 55 do want to stay in contact lenses. Now, what are all these issues with monovision? Well, many people are not successful. They report halos and glare. I know my patients report night driving safety concerns, difficulties with computers and digital devices, and we are on computers and digital devices all the time. That lack of depth perception, lack of binocular vision, especially in those advanced stages, and the challenge of refitting to a multifocal after fitting with monovision. So why should we start early? Well, it's so much easier to fit a patient in a multifocal contact lens with a low ad compared to a high ad. It helps with adaptation. And we don't want to just kind of be lazy and have the non-dominant eye and push a little plus and push a little more plus, and then finally we're in full-blown monovision, and there's a 2 diopter or 250 ad in that non-dominant eye. So I would encourage you to start talking to your patients about presbyopia even earlier. You can talk to your 20-year-olds because their parents are becoming presbyopic, especially talking to the 30-year-olds, educating them on presbyopia, because we're on digital devices so much. And I just tell my patients, even if they're not symptomatic, if we're not worrying about it, that is fine. We don't have to do anything. But I like to tell them that there are contact lens options for them. And I talk to them about presbyopia, explain what presbyopia is, and when they're ready, when it's time, then there are contact lenses, and they come back and say, "Oh, yes, I know you told me that there's some sort of contact lens I can wear. I'm having a lot of trouble up close." I have this slide in here again because the multifocal practice benefits are just the same as for anyone who wears contact lenses. It really helps differentiate your practice, increases referrals, increases revenue. So what are the keys to success? Well, we want to identify these patients and identify them early. A person does not have to be 40 years old to fit in a multifocal. If they're on the computer a lot during the day, if they have multiple screens, and I love to ask this question, how many digital devices do you use, including your watch? And the numbers are getting higher. So it used to be around 3, now it's at least 5 for most people. And remember, our electronic medical records are in there too. We want to understand the science. So multifocal lenses really do outperform monovision. We want to know the strengths and weaknesses in low light, but we all have our phones, so we can use our phone for lighting situations. We know that contrast is an issue. A newspaper, for example, is a really good example of poor contrast. And we want to set realistic expectations. I fit a patient this week with a multifocal for the first time, and he was in his 50s. He said, "This is amazing. I can't even feel these lenses. I can see everything. I can see distance. I can see close up." But he did complain that he can see his wrinkles. And I said, "I'm sorry. I'm sorry you can see your wrinkles, but I'm really happy that you can see so well." And going over the fitting process and fees and consent forms are also very important factors. Now, this is from the BCLA Clear report. This is Catherine Richdale's report on contact lens optics, which I just think is so well done. So if you're nerdy like me and just love reading studies about contact lenses, I would encourage you to read the entire BCLA Clear report or different sections of it, but this report is really great. So this is just one figure that explains the difference between bifocal and multifocals and all the different designs that we have out there. So there are many different options. Now, we know in presbyopes, we want to, and everyone, we do want to avoid contact lens discomfort. We want to avoid contact lens dropout, and we want to keep our patients in contact lenses. So we can change modality. We can change to a daily replacement lens. We can also change the solution to a hydrogen peroxide-based solution. And this came out of TFAS back in 2013. So just a great example of how to keep our patients in contact lenses. Well, what if they have astigmatism? Astigmatism is really common. And I always look at about 0.75 diopters of astigmatism at the level where I do want to correct for it in a contact lens. And you might say, well, that doesn't make sense. So like, what about if they're minus 10 with 0.75 diopters? And that's when you have to really consider, is the astigmatism in the dominant eye? Is it in the non-dominant eye? Is it corneal astigmatism? Is it residual astigmatism? And what if the corneal astigmatism does not match the spectacle astigmatism? A tip is to correct that astigmatism first, but we do have really great soft toric multifocal options. And I say that honestly, because years ago, they were not great in my opinion. And I have many patients that just love a soft toric multifocal. And of course, we have tons of different custom soft toric multifocals as well. We have monovision, and then we have single vision soft toric with reading glasses over. But we have more. So that doctor that said, well, is there always a compromise? And I said, absolutely not. This is what I'm thinking. So we could start, say, with a soft multifocal contact lens, which is a great option. And there are many daily replacement soft multifocal lenses. For those of you listening, yes, please, I would like a daily replacement soft toric multifocal, which is not quite available yet. But we have many different tools in our toolbox. So we have corneal lenses, corneal gas permeable lenses. We have hybrid lenses with a hard center and a soft skirt. We have scleral lenses that come in multifocal designs as well. And the upper left here is a diagnostic scleral lens. You can see all those markings there. So I'm just going to go over one of the steps that I think a few of the steps very quickly here when we're fitting multifocals. So getting an accurate refraction and an accurate new refraction. So if I saw the patient before, then I want to just double check the refraction if it was more than 6 months ago. But if I did not see the patient before, then I do want to check the refraction. Eye dominance, this is so incredibly important. And I like to do this first, actually. So if a patient comes in wearing glasses, for example, with pretty good vision with their glasses, you can put a plus 125 or plus 150 over and check their dominance. Now, you can also do this in the phoropter using the handy dandy retinoscopy lens in the ret lens or the R lens in the phoropter to check dominance. And of course, when you finish the refraction, you can just use that. You could even use it in a trial frame and check as well. But there are different ways of checking eye dominance, and sensory dominance is the way that we want to check it. That's the sensitivity to blur. So when I put the lens of plus 150, for example, over each eye, I like to ask my patients which makes it more blurry. And the more blurry eye is the dominant eye. And that's a very, very simple, very easy way of checking it. Compared to sighting dominance, you know, the little triangle, looking through the triangle, looking at one eye at a time, the sensory dominance will help you far more when fitting multifocal lenses. And now I've come to actually writing this down, right eye dominant sensory method or something like that. So I know which eye is dominant. Now, sometimes I ask my patients if they, say, are a photographer with an old-fashioned camera, if they shoot any sort of rifle or gun, I will ask them about what their dominant eye is, but only after I check it. And there are studies that show that sighting and sensory dominance do not correlate completely. And determining lens modality, so we can ask our patients what they do, what they've tried before, what works, what doesn't work. But because we have so many different tools in our toolbox, we can provide excellent vision for our patients with a variety of options. Now, the other step I'm just going to highlight here is the binocular distance over refraction. So we want to use quarter diopter steps, so 0.25. I would encourage you to push plus here. So even plus a quarter sometimes can make a huge difference. So plus a quarter over each eye. If a patient accepts plus a quarter over one eye, put plus a half over that eye. And I like to avoid minus, but sometimes you do need minus a quarter. If you have an accurate refraction, if you're fitting a soft multifocal, then you should be very, very close within a quarter diopter, but even just a quarter diopter of plus can really, really help. And adaptation is so important when we're talking about multifocals. So make sure that the patient knows that there is an adaptation time. I like to tell my patients it takes about 2 weeks to get used to their lenses. I love it when I'm fitting multifocals in the practice and my patient says immediately pretty much, oh, everything's great. I can see everything, like the patient I told you about just this week. But sometimes things look a little bit overlapping or double, but more of an overlapping double or blurry, especially when reading. So providing realistic expectations, and that might be maybe trying the lenses at home first, not driving immediately with them. Remembering that lighting is so incredibly important, so good lighting, and also the importance of wearing the contact lenses to get used to these multifocal lenses, and also wearing the contact lenses for approximately 4 hours so that we can check and evaluate the lenses on eye, and then of course remove the lenses and evaluate the ocular surface as well. So if patients are happy, you don't need to change anything. If they are not happy, doing a binocular distance over refraction. And if we're fitting a soft multifocal, using that fitting guide, the advanced or the troubleshooting fitting guide is really, really important. Now, many different brands have the initial fitting guide, but I would argue that the troubleshooting is even more important. We don't want to make a lot of changes here, and we do have many different types of contact lenses. So this is a beautiful picture of the desert, because sometimes eyes are so dry, they feel like a desert. And we have options for daily replacement, reusable lenses, different materials, different care systems as well. So I'm going to highlight these studies because I am a very huge fan of hydrogen peroxide-based systems, but I will say I'm a little bit more of a fan now based on these studies. So these were looking, so if parameters don't allow and they cannot wear a soft daily replacement lens, then they need to clean the lens every night. So hydrogen peroxide-based systems are effective against COVID-19. This is looking at a study from the EPA. And within 1 minute, 0.5% solution of hydrogen peroxide can cause a greater than 4 log reduction in COVID contamination. Now, also povidone iodine, which we don't have here quite yet in the US, there is a greater than 4 log 10 reduction in coronavirus within 15 seconds. So 2 great options here. This is a study that looked at 5 multi-purpose solutions against COVID. 3 multi-purpose solutions did not eradicate COVID at the manufacturer's recommended disinfection time, and hydrogen peroxide and povidone iodine both significantly reduced the numbers of coronavirus to less than the detection limit. So that's a great option for patients that might be concerned about wearing contact lenses. Now, many presbyopes are not wanting to wear contact lenses all day, every day, and are interested in occasional wear, which is very convenient, fantastic for dry eye and ocular surface disease, and less of a case contamination. And hopefully you haven't seen a case like this, but I saw one recently. It's so disgusting. The Tempo registry study looks at the rates of adverse events with hydrogel and silicone hydrogel lenses, and with daily replacement lenses in the SiHy group, 0.4% per year, the hydrogel 0% per year. So the rates are significantly lower compared to reusable lenses of 3 to 4% per year, thus improved safety outcomes with daily replacement. And I would encourage you to share this information with your patients as well. Now, we do have many different types of great daily replacement multifocal lenses that are available for our patients. And in case you're fitting lenses, such as scleral lenses in office and reusing them for patients, here are guidelines, the technical report, so guidelines for handling of multi-patient contact lenses in the clinical study. This publication can be downloaded free of charge. I would encourage you to have the right-hand side here on your wall or somewhere in your practice for your staff. It's great. We have it up so our staff can look to do what to do for each type of lens. Okay, so hopefully that convinced you that multifocal lenses are great and patients can wear them. Now, moving on to the next one, fact or fiction. Scleral lenses are only used for irregular eyes. Well, scleral lenses have multiple benefits. So they bathe and protect the ocular surface. They correct irregular astigmatism, but they are actually the first type of contact lens that were introduced and support and protect the surface of the eye. So scleral lenses, of course, can be used for people with severe dry eye and severe irregularities like keratoconus and keratoglobus. But there are many newly emerging scleral lens indications. And there are studies to support this as well. So the studies demonstrate that scleral lenses are great for soft toric lens wearers who experience discomfort or fluctuating vision or dryness. For those with high refractive errors, even those with presbyopia, there are lots of multifocal options. Scleral lenses are great for allergies, to control allergies, and also for people who play sports and do different sorts of, I love motorcycle riding is a big one, or bike riding. Scleral lenses are really very stable. So we can fit normal eyes with patients who are not happy. Maybe they wear corneal lenses and they fly off their eye or dislodge, or their eyes are dry, even a little. For mild dry eye, scleral lenses are great. So when we're fitting scleral lenses for normal eyes or regular corneas, it's just the same as when we're fitting for irregular corneas. And this came from the TFOS Do's Do and indicated that scleral lenses are step 3. So this is after prescription eye drops and prior to, say, surgical punctal occlusion or something like that. And scleral lenses are a great option. Now, for those who have even, say, mild dry eye, this was a study that looked at hydropeg surface coating for scleral lens wearers with dry eye and showed the benefits of scleral lenses in this population. So when we fit scleral lenses, we do want to measure the horizontal visible iris diameter. We also want to measure the vertical visible iris diameter. We want to evaluate the central clearance, limbal clearance, and scleral landing, and of course, over refract. So we have many different ways of doing this now, which is great fun. We have diagnostic lenses. We can measure the corneal sclera and with scleroprofilometry. We also have impression-based scleral lenses. So just like fitting soft lenses, if there is a fitting guide, we want to follow that fitting guide. If there's not a fitting guide, but for normal eyes, there tends to be a fitting guide. If there's not a fitting guide, definitely measuring keratometry values, measuring corneal tomography or the entire cornea if you have that as well. And of course, scleral lenses are fit on sagittal height. And so very different than other types of contact lenses. And here you can see some examples of scleral lenses. So the one on the left, the HVID is 11 millimeters with a SAG of 25-30, and the one on the right, the HVID is 12.6 millimeters with a SAG of 40-30. And we want scleral lenses to evenly align on that scleral conjunctiva. But there are many different patients that a scleral lens is just a great option. Again, another tool in the toolbox. Okay, this is our last fact or fiction. Contact lenses should always be fit on the same day as the eye exam. And it depends. It depends. So I'd encourage you to, and this is my new way of looking at patients, and I'm going to share it with you, but take the global view. So before you dive into that slit lamp, before you look at those collarettes on the eyelashes, for example, I'd encourage you to look at your patient from across the room. Look at their fingers. Do they have rheumatoid arthritis? Look at their eyelids. Do they have sleep apnea? And just take that broader view. Now, this is really very helpful, I found, when fitting scleral lenses too, looking outside of the slit lamp prior to looking in the slit lamp. And just looking, you could see areas of blanching or impingement. But you can also look at the ocular redness. Are their eyes injected, or are they nice and white and quiet? What about the eyelid position? Do they have some ptosis going on too? So this is the way that I've been looking at patients, which I find to be quite helpful. Now, we do want to evaluate the ocular surface prior to fitting contact lenses. So we want to look at the eyelids and lashes, meibomian gland dysfunction, and Demodex and blepharitis. We definitely want to stain the cornea and conjunctiva, checking tear breakup time, using non-invasive methods if you have them, flipping the lids to look and see if there's any allergies or any inflammation there. This is all very helpful and very important prior to fitting contact lenses. And we know that contact lens wear is an independent risk factor for dry eye, especially meibomian gland dysfunction. So we want to evaluate for meibomian gland dysfunction, even non-obvious meibomian gland dysfunction, by gently pressing on the eyelids or using a meibomian gland evaluator to do that. Ocular rosacea is incredibly prevalent. So looking at the increased lids, the telangiectasia, those tiny little blood vessels on the eyelids, we want to look at the meibomian glands and look for dropout, even with lights or transilluminators, or if you have imaging meibography, that's great as well. And a contact lens really affects the tear film. So it divides the tear film into the pre and post tear film. and thins the tear film more rapidly. And so it leads to faster evaporation of the tear film. So here you can see some nice images of the pre-lens tear film and the outer lipid coating, and the post-lens tear film with the thin aqueous mucus layer. So it's really, really important to prepare that dry eye for contact lenses. Now, it depends, in my mind, it depends on if it's a normal cornea or if it's a patient with an irregular cornea. Those are two different answers, but here I'm talking about normal corneas. So if it's an irregular cornea, say someone who has keratoconus, and I'm going to fit them with a lens, whatever lens it is, and manage the ocular surface at the same time. But if it's someone with a normal cornea, I definitely want to prepare that eye for contact lens wear and explain to my patients that it's really important to manage dry eye and that it is a chronic condition. So dry eye is chronic. There's a lot of homework involved, and treatments can last for weeks or months or even longer. But going over the benefits. So, for example, fitting a soft multifocal contact lens on a really poor ocular surface with a poor tear film, it's going to be tough, and a patient is not going to be happy. But even fitting, say, a normal eye in a soft lens or soft toric lens, I do explain to my patients and can get some pretty rapid results if patients address the ocular surface. So we have so many clinical pearls for success and so little time to talk about all of them. However, I would encourage you to take the approach of all of these different options. We have eye drop options. We have nasal spray options, goggles, humidifiers, and all sorts of home therapy options for the eyelids. So all sorts of different eyelid cleansers here. I do like to talk to my patients quite a bit about makeup and the ocular surface because it really does affect the dryness of the ocular surface, and it does affect contact lens wear. So talking about, there's a great website here, the EWG Skin Deep website, and that you can type in actually certain products in makeup and sunscreen, which would also be considered a product there too, to see if it's drying on that ocular surface. We have topical medications. We have oral medications. We also have different types of supplements like omegas, and certain supplements have different ingredients that are very helpful for the ocular surface, such as GLA, with studies that support that as well. We can move on to plugs and serum drops, amniotic membranes, and of course, scleral lenses, all sorts of different warm compresses. But this study I use and I share with my patients that using a warm compress one time a day, and I don't prescribe the time of day, one time a day for 10 minutes increases comfortable wearing time for 3 hours. We have some future fun stuff coming to help with Demodex blepharitis. And if you look at studies on Demodex, that really does affect contact lens wear and contact lens comfort. There are many different alternative technologies, in-office technologies that are very helpful. And really, it's important to treat that underlying cause of the ocular surface, which is going to help with comfort. It's also going to help with the cosmetic appearance of the patient, but it will definitely benefit contact lens wear to help with contact lens retention and prevent contact lens dropout. So I'm going to open it up now for questions. I do want to thank you for your time and attention here. This has been great fun. Okay, so it looks like we have some questions. And how do you decide which contact lens to fit? Well, it really depends. So I like to ask my patients, what have you tried before? What did you like about your contact lenses? What did you not like about your contact lenses? What worked? What did not work? Also the color question. Do you want to change your eye color? Because you can fit a patient in any sort of contact lens, but if it doesn't come in blue or purple or whatever it might be, they might not be happy and they might not love that one. A question about recycling and plastic. What about the blister packs that the one-day contact lens come in? And yes, so those can be recycled as well, with the other contacts in the number 5 recycling. And then another question here too. So how do you decide which solution to use for contact lens wearers? Well, here in the US, for hydrogen peroxide, we have one option at this point, which does need to soak for 6 hours or overnight. I would love an option that would be less time than that. So I do have some shift workers. I have, for example, a nurse or someone who works different hours, or some students who don't have the 6 hours to use a hydrogen peroxide. So sometimes I'll use a multi-purpose solution and a hydrogen peroxide solution. When we're talking about soft multi-purpose solutions, we do have various types, but a brand name is important because it's a known product. And when we talk about ones for rigid or corneal lenses or scleral lenses, we have some great options there as well. And the filling solutions are also important, the FDA filling solutions. So there's so many options, so many fantastic options for contact lenses for our patients. And I hope that you can use some of these options in your practice, bring them back to your patients. And I really hope that it grows your contact lens practice. So thank you again, and I hope to see you soon.